Well, since afatinib was approved for first-line treatment, a lot of doctors are just more comfortable, at least in the U.S., with drugs like erlotinib. Afatinib's, I think, difficulty or challenge is that it's associated with more GI toxicity, stomatitis, diarrhea, and I think that's something that a lot of doctors, a lot of medical oncologists are simply just not comfortable with. They would rather do something they're more familiar with, like erlotinib. So when you're using afatinib, if you're kind of an exon 19 deletion believer that afatinib is the drug to use in that population, you need to know how to be prepared for toxicity. So usually starting at the full dose, 40 milligrams a day, you're going to encounter some form of toxicity, whether it's the typical paronychia, nail, skin changes, or more serious GI toxicity. So we have the usual strategies of either, well, first of all, holding therapy, usually just a few days or sometimes a week will allow resolution of all of those symptoms. And then when you resume therapy, starting a lower dose, like 30 milligrams a day, as was done in this case. We do use the typical anti-diarrhea medications, things like loperamide or Lomotil, to help combat the diarrhea during those periods.